Hello, today we're going to talk about bone marrow examination and bone marrow failure. We did discuss this in the introductory hematology course. We did have a bone marrow chapter. Some of these things are going to seem a little bit familiar, but before we go into the failure, we're going to spend a few minutes talking about the bone marrow itself and how we do look at the bone marrow. All right, so bone marrow is found in a couple different locations in the body. At birth, nearly all bones have the hematopoietic marrow, which is known as the red marrow. Between the ages of 5 and 7, the yellow marrow begins to replace the red marrow in the long bones of the arms and legs, as you can see by this picture in the bottom right. In adults, the hematopoietic or the red marrow is limited to the axial skeleton and the proximal portions of the extremities, also as seen in the picture in the bottom right. So the bone marrow sites that we usually sample depends on the age of the patient. In adults, we use the iliac crest, which is usually just above the buttocks and the back. And occasionally they can use the ribs or the vertebrae, but this is going to be the most common area that we do draw the bone marrow from. In children under 1 year, they usually use the front and middle surface of the tibia and the leg. And sometimes children I've seen around the ages between 5 and 10, they'll actually use the sternum as well. So the procedure that is used for a bone marrow, there's two parts. First, they'll take an aspirate. Okay, so they use a syringe and they actually draw the marrow from the inside of the bone. As seen in the picture that we had prior to this, you could see the syringe that was actually drawing. The doctor would then take that syringe and they would pass it off to the lab tech who would make a slide. And I have a picture coming up next on how those smears are made. It's usually a little bit different than how a peripheral smear may be made. The next part of it is that core biopsy specimen. You can see from the little video down in the bottom right that they actually take a kind of like a tube-like section, I guess it looks like a little dowel of marrow and bone, to kind of so they can see the anatomic relationship of the fat and connective tissue that may be found within that. So they want to see the different layers of marrow. If they were to pull it all out and it doesn't have a lot of cellularity to it, it could be all fat per se. They may have something like aplastic anemia, so there would be no cells. You can also have a very tightly packed marrow, such as leukemia. So this is an area that the pathologist might look at as well, is that core that they do get. So in this video here that'll pop up in a second, we're going to see that those smears are made differently than they are from making a peripheral smear that we do on a daily basis. Oh, and my video is not showing up here.
In this video, I'm going to show you how to make two different types of bone marrow smears. The first one, you're going to place a drop of blood on top of the first slide, and then you're going to drag the second slide across it. So you go ahead and you place your drop, and the second slide is going to be flat on top, and you pull it away, and you get a bone marrow smear like that.
All right, so sorry my embedded video didn't work, but you were able to see from that video that they do add a drop of blood to the smear and then they pull another slide across the top of it to make a little bit thicker of a smear so that they can see a lot of cellularity within there. Okay, so what are some of the reasons that somebody might actually need a bone marrow exam? Well, usually it's not required for anemia when the reason is seen by lab test alone. So if they were to find out that somebody had a low H&H, they would perform a serum iron or folate level. If there was something wrong with those, they would obviously replace those deficient minerals and hope for the best that it would cure the issue that they're having. We usually only perform it when we see blasts in the peripheral blood, pancytopenia patients where all of the cell levels are low, or staging Hodgkin lymphoma or non-Hodgkin lymphoma and carcinoma to see what stage they may be at within that. We only perform that when it's essential for diagnosis or patient management. So some of the characteristics of a normal bone marrow aspirate, when you look at these two slides on the right, you can see little crystals within the blood. Those are actually bone spicules. And when you go to make that crush smear that you saw that man making, that wasn't an actual bone marrow smear, that the sample that he was using, because if he did have a good sample, you would be able to see and actually feel these bone spicules between those slides as you were pulling them across. So we do want to have those present. Those bone spicules have a lot of, means that you have a really good sample. We can estimate the cellularity by observing the proportion of cells to fat vacuoles as well. So if you look at the bottom right, the white areas are all fat vacuoles, and we want to make sure that there's plenty of cellularity in there for the pathologist to be able to look at it and to be able to do an adequate cell count within the bone marrow. So when they look at it under oil immersion, just like you would look at any other peripheral smear, they'll actually count 300 to 500 nucleated cells to obtain a reliable differential count. They also look at the myeloid to erythroid ratio. A reminder of that, normal is 3:1. So it's a parameter in evaluating the normal or the marrow function to make sure that it's doing what it should be doing. And, if it's kind of like doing a regular differential, right? So they just want to make sure that everything is normal, and this is where they would start diagnosing certain types of leukemia. They also do some cytologic evaluation. So the largest cells in the bone marrow are megakaryocytes. Remember, those are the massive cells that have little platelets that kind of come off of them. We can see osteoblasts and osteoclasts in the bone marrow, which make the bone. We can see adipocytes and endothelial cells, and under low power, we scan for abnormal clusters of cells such as tumor cells. That bone core biopsy that we mentioned earlier, here's another video of that. So that provides an intact portion of the bone marrow. So you can actually see the first part that comes out is actually the bone marrow itself, but on the end of it, there will be a piece of bone from where the marrow connects to the bone. So that's important as well. So some of the things that they look at and that they would report, the cellularity of the bone marrow, the ME ratio, the maturation of the myeloid and erythroid series of cells. They look at eosinophils and basophils, including mast cells, those big megakaryocytes that make the platelets. Other cells, is there lymphocytes, plasma cells, osteoclasts, fibroblasts, any stromal abnormalities within the structure? Is there hemosiderin content, which would mean iron abnormalities? Any vessel abnormalities or bone changes that could be present that could mean various types of things, even types of bone cancer per se. So now we're going to look at what happens if we see the bone marrow fail. There's a few different diseases. You're going to have to be able to differentiate between them. So when we say bone marrow failure, we're referring to like a reduction or a ceasing of blood cell production affecting one or more cell lines. It's important to know that pancytopenia means that all cell lines would have some type of a decrease. If somebody has bone marrow failure, they will have pancytopenia in the bone marrow and in the peripheral blood. So bone marrow failure could include any of the following. You could have a destruction of the hematopoietic stem cells due to injury by drugs, chemicals, radiation, viruses, or autoimmune disease. You could have premature aging or apoptosis of stem cells due to some type of a mutation. You could have a B12 or folate deficiency that could cause issues because we know we need those for normal cellular development. You could have disruption of bone marrow environment that supports hematopoiesis by some type of reason, let's say even broken bones, really massive broken bones, and we can start seeing marrow cells in the peripheral blood just from that. Decreased production of hematopoietic growth factors or hormones and loss of normal hematopoietic tissue due to some type of infiltration of the marrow space with abnormal cells. Think of leukemias and things like that, where those cells might start to invade and grow like a tumor within the bone. And true story, a little boy, one time I went up to draw blood from about an 18-month-old boy. And when I got there, I was getting my things ready, and I heard the pediatric oncologist talking to the patients, or the patient's parents, I should say, because he's 18 months old. And they said the reason that they found that there was something wrong is the little boy had just started walking, but all of a sudden he would take 2 steps and fall to the ground in excruciating pain and crying, like he wouldn't walk anymore. And it turns out that all of these abnormal, cancerous cells or malignant cells that had invaded his bone marrow were actually growing so fast that it was cracking his bones from the inside. So we can see that with children as well, a lot of bone pain as those cells are proliferating abnormally within the marrow. All right, thrombocytopenia can result in bleeding if you don't have enough of those as well. We can have a decrease in RBCs and hemoglobin, so we'll see the anemia first in most cases. You can see long-term neutropenia, which could increase the risk of bacterial and fungal infections. Obviously, you need those things to fight those off. So, the first disease we're going to talk about is aplastic anemia. This is a bone marrow failure syndrome resulting from damaged or defective stem cells. We see pancytopenia, reticulocytopenia, bone marrow hypocellularity, and depletion of hematopoietic stem cells. This can be acquired or inherited. So if we have an acquired case, usually it's idiopathic, which means we don't know what caused it. So that's important to know. We have a lot of idiopathic things that we talk about over the course of your time here as an MLT student. But whenever you hear idiopathic, it always means we don't know, okay? It can be classified as secondary when we can identify it. For example, drugs, radiation, chemicals such as benzene. Usually if we figure out what it is and we take away that agent that's causing it, you will recover. We can have idiosyncratic reactions to drugs or chemicals where the bone marrow failure is unpredictable and unrelated to dose and does not recover when the agent is withdrawn. So if it is because of a chemical and you don't recover, the difference between the first one is you did recover here, you don't recover. You can have an infection. They're finding Epstein-Barr virus causing a lot of problems in people. Everything from autoimmune diseases to actually pretty much all autoimmune diseases is what Epstein-Barr virus is being responsible for lately. HIV, hepatitis, and human parvovirus can cause aplastic anemia. Pregnancy, autoimmune disorders, sometimes with paroxysmal nocturnal hemoglobinuria, which we'll talk about a little bit later, those can all be a cause of aplastic anemia. So with this, we see a quantitative and qualitative deficiency of hematopoietic stem cells. The hematopoietic stem cell and early progenitor cell is identified by expression of that CD34 surface antigen. So if we do flow cytometry, we'll measure the CD34 antigens and it'll be 10 times lower than normal in an aplastic anemia patient. We see an increase in apoptotic CD34 cells due to increased expression of FAS receptor that mediates apoptosis. When you see that FAS receptor, that is like a predetermined cell death marker. So obviously we don't want to increase that because then our cells are going to die faster. But with aplastic anemia, your bone marrow all in general converts to something that is not usable. The bone marrow stroma is functionally normal. It produces normal or increased amounts of growth factors. So the FLT3 ligand is a growth factor that stimulates the proliferation of stem cells and progenitor cells, is actually 200 times higher in aplastic anemia. So the body is trying its best to do what it can to increase a situation that's difficult to increase with a lack of marrow. There will be a depletion of hematopoietic stem cells and progenitor cells. We can have a direct or indirect type of situation here. So direct would be like a cytotoxic drug that would affect the DNA. Indirect would be exposure to drugs that resulted in autoimmune T-cell attack. So there's 2 different ways. Either the drug itself does it or the drug causes your body to destroy it. Some of the clinical findings in somebody with aplastic anemia, it can be asymptomatic to severe. They're usually pale, they're tired, they're weak. It can result in serious cardiac complications if they let it go too far. Some other things that we'll find, petechiae, bruising, nosebleeds, bleeding gums, menorrhagia, retinal hemorrhage, intestinal bleeding. All of that is secondary to thrombocytopenia. So it's a result of having low platelets from this abnormal bone marrow environment. Fever and bacterial fungal infections occur because of the low amount of white cells. We usually don't see splenomegaly or hepatomegaly with this one, as we may in some of the other anemias that we're going to discuss. So lab findings, as we've mentioned this word 100 times already, pancytopenia, all of the cell lines are going to be low. We're going to have a low hemoglobin. MCV is usually normal. Decreased reticulocytes, because obviously that's what's showing that the bone marrow is working, is having increased retics. You would have decreased retics. Toxic granulation can be present. Serum iron and transferrin are usually increased. And bone marrow aspirates and biopsy samples have mostly fat cells with patchy areas of cellularity. So whenever we talk about aplastic anemia, in general, people say, yeah, their bone marrow turns to fat, rather than having all the red cellularity. The treatment for this is to discontinue the causative agent if we know what it is. If they're working in an environment with a lot of benzene, obviously remove the benzene and hope for the best. Platelet transfusions may become necessary. RBC transfusions, hematopoietic stem cell transplant if it's severe and you're less than 40. If you're greater than 40, they usually use an immunosuppressive therapy because in most cases it's probably an autoimmune type of issue. They do want to monitor that cytopenia in abnormal cells to make sure that this is really the case. The next type of aplastic anemia is an inherited one, Fanconi anemia. This is an autosomal recessive chromosome instability disorder characterized by aplastic anemia, congenital abnormalities, and a cancer susceptibility. As you can see from this picture on the right, this little guy has skin pigmentation, a short stature, and hypogonadism, which obviously you can't see from the picture, but they do sometimes have those claw-type hands. Sometimes they're missing one of their fingers, as you can see from his picture here. So this is the most common of inherited aplastic anemias. The lab results are very similar to an acquired aplastic anemia. 90% by their 30s develop bone marrow failure. So death by 20 from complications is very, very common, or they develop leukemia. Treatment would be transfusions, giving them androgens for the hypogonadism, providing cytokines to help them. Hematopoietic stem cell transplant is another one that may be helpful. The next one is dyskeratosis congenita. This is a rare inherited bone marrow failure syndrome. It's characterized by mucocutaneous abnormalities, bone marrow failure, and pancytopenia. There's abnormal skin pigmentation, dystrophic nails, as you can see by the top picture. The nails are hardly there. And oral leukoplakia, as you can see from the bottom left, that's where they have like a white plaque on their tongue, between the ages of 5 and 10 years. These people are likely to develop an acute myeloid leukemia, myelodysplastic syndromes, or other epithelial malignancies. Death usually occurs before age 20. Again, stem cell transplant would be desirable, providing androgens and growth factors. Another quick mention on this slide is the Shwachman-Bodian-Diamond syndrome, SBDS. This is one that's characterized by pancreatic insufficiency. None of the other ones have pancreatic insufficiency, just this one. Cytopenia, skeletal abnormalities, and a predisposition for hematological malignancies as well. But the one standalone on that one is the pancreatic. A couple other forms, pure red cell aplasia. This is a rare disorder of erythroplasia characterized by severe decrease in erythrocyte precursors in otherwise normal bone marrow. We can have a severe anemia, reticulocytopenia, which is having low retics. In all these aplastics, we see a low retic, so that's something that will stand out to you. A normal WBC and a platelet count. It's also usually normocytic. The cells look normal, there's just less of them. It can be acquired or inherited. Acquired is usually due to an autoimmune disorder, a tumor, some type of infection, or hemolytic anemia, sometimes exposure to drugs as well. The inherited cause, which is congenital, you're born with it, is Diamond-Blackfan anemia. This one, the stem cells are defective and the cause is unknown. Congenital dyserythropoietic anemia is another group of rare disorders characterized by a refractory anemia, which means it kind of comes and goes. Reticulocytopenia, hypercellular bone marrow with a marked ineffective erythropoiesis. The interesting thing about this is the distinctive changes in the erythroblasts, like giantism and multinuclei. Look at these cells on the right here. So you've got kind of a normal nucleated red cell here. Look at this giant multinucleated red cell. Isn't that crazy? Yet another one over here, and this one, it's got this tiny little nucleus here, which looks like it's on its way out. But certainly, look at the difference between a nucleated red that's normal and what those look like. So quite different. With this, we see iron overload, jaundice, cholelithiasis, which is like gallstones, and splenomegaly on this one. The next one is myelophthisic anemia. This one's hard to say. With that one, there's an infiltration of abnormal cells into the bone marrow and a destruction and replacement of normal cells. Tumor cells, leukemic cells, fibroblasts, and inflammatory cells may take over the bone marrow. And due to an unfavorable bone marrow environment, stem and progenitor cells will move to the spleen and liver and establish extramedullary hematopoietic sites. So this one tends to show itself in the spleen and liver, where some of the other ones may not as much, okay, due to the extramedullary hematopoietic sites. We see normocytic, the dacrocytes, which are the teardrop cells, probably come from them heading through the spleen. Megakaryocyte fragments might be seen along with giant platelets. So the last one is anemia of chronic kidney disease. This is from an inadequate production of erythropoietin by the kidneys. So that makes sense, right? If you don't have erythropoietin, you're not going to make a lot of red cells. So due to chronic, it can be due to chronic blood loss, iron loss, and folate depletion due to dialysis. Usually it's normocytic, normochromic, with a normal or decreased reticulocytes because you don't have the erythropoietin to kind of get that process moving. All right, so that ends our presentation on aplastic anemias.